at the beginning, by the way, we are recording the meeting and we will definitely share the video with all of you. And however, in fact, I would like to share it with my colleagues at the university, some of them who are busy at the moment. But it is very important for them to know the details of this meeting. Okay, at the beginning, let's start the meeting with the introduction of our experts. And it's a pleasure for me to introduce my talented, enthusiastic student, Amirhosein Mohamadi. He's here with us to help me to moderate this session. Okay, Amirhosein, would you please introduce our experts?
Yes, of course. Hello and welcome to all our participants and our esteemed guests. Today, we are thrilled to have you with us with the webinar titled Global Advancements in Medical Education, Challenges and Breakthroughs in Dentistry. It's my pleasure to introduce our esteemed panel of speakers. We have Dr. Ronald C. Gorter, Associate Professor at ACTA, the Netherlands. Dr. Gorter specialized in the behavioral aspects of dentistry and dental education, with a focus on work stress, burnout, and job satisfaction. He is the editor-in-chief of European Journal for Dental Education and has contributed significantly to the field. We have Professor Muneer Babar, Associate Dean at IMU University, Malaysia. Professor Babar is an expert in dental public health and educational technology. He has made notable contributions to curriculum development and research in dental education, particularly focusing on empathy and dental home visits. We have Dr. Thananphum Osathanon, Associate Dean at Chulalongkorn University, Thailand. The leading figure in oral biology, Professor Osathanon has published extensively and has been involved in developing competency-based curricula and national accreditation for dental education in Thailand. Professor Azim Mirzazadeh from Tehran University of Medical Sciences. Professor Mirzazadeh has been instrumental in revising the medical program at TUMS and has significant experience in curriculum development and accreditation, serving as chair of the Department of Medical Education and director of the Education Development Center at TUMS. Thank you so much.
Great, thank you for introduction. We would like to start the meeting with a presentation by Professor Gorter. I invite him to share his ideas on dental education. Professor Gorter, the platform is yours.
All right. Let me see. I hope you can see the PowerPoint.
Yes.
Yeah, first of all, thank you very much, Puyan, for inviting me. It's been a while since we met live. It was 2019. And since then, we have had a few occasions to meet online. And thank you for that. Here you see I'm based in Amsterdam, which has a very nice little center with canals. And if you ever have the chance to visit the Netherlands, then springtime is a good time. You can see many tulips, as you call it, lale, isn't it? Yeah, I remember. And in the middle, you see the Academic Center for Dentistry in Amsterdam, where I'm based. And on the left side, and in my background, you have an image of our clinical floors. It's a pretty new building since 2010. So we are very happy that we could move over to this new building. I am associate professor with research and teaching on dentist-patient communication and oral health education. My background is psychology, and I've been working at the ACTA, as we call it, Academic Center, for over 30 years already. So that's been a long time. and we've seen a lot of changes. Also, in focus are team aspects, working together as dentists with oral hygienists, with medical trained professionals is an important part of our education. And also professional behavior or professionalism in general is a focus in our education. I teach health psychology, and much of my research was on stress and well-being among dentists and how to prevent dentists from burning out, which is still an issue in many countries. Internationally, I'm executive member of the Association for Dental Education in Europe, and I'm still editor-in-chief of the European Journal of Dental Education, but I'm handing over this position to my colleague from Cristina Manzanares, a professor from Barcelona, and she will take over for the next 4 or 5 years. That will make a lot of difference in workload. And I'm also representing the ADE at what we call the Platform for Better Oral Health in Europe, which is a European platform in which many organizations participate in order to bring oral health under the attention of the European authorities. And also education is important. I will.
Sorry, Ronald, sorry for the interruption. Could you please make your PowerPoint full screen?
Okay. Okay. This is better?
I think there is a technical problem. I think,
Can you see it like this?
yes, we can see.
Because if I do it full screen.
Okay, no. Okay. I think it's better.
This is better.
Let's go ahead.
If you duplicate it, it will be only one screen then.
Okay. Shall I continue like this?
Yeah, no, it's sure.
Yeah, please go ahead.
Okay. So I will say a few things about the ADE as the European Association, and I will focus a bit on what we have now developed called the Graduating European Dentist. These are like guidelines. And later on in our meeting, I will say a few things about what we developed in Amsterdam on virtual reality in dental education. But I will do that later. And because that will give an idea about current changes in dental education and looking forward to the future of dental education. Also, later in the presentation, we can think about how to develop our dental education looking into the near future. Now, the Association for Dental Education in Europe is a pretty large association, and one of our main activities is organize meetings. Like the next meeting will be in August in Dublin, Ireland, and it's a special one because we will celebrate our 50-year anniversary. So that's quite an occasion. Already 50 years, the association has been trying to reach the goals that were set. And a year later, it will be in Budapest next year. Now, when we think about dentistry and dental education is only very short in existence. It didn't exist at all. But if you look at this lower jaw, this was found in the Himalayas, and it's estimated to be about 1,000 years old. And they could already see that rotating treatments had been done in one of the molars. And they think that maybe it was like a wooden stick with an iron point to relieve the pain from somebody who lived there. So, of course, this is difficult to imagine how you would do this with an upper jaw also. But the idea is that already some kind of treatment existed. And if you look at paintings all over the world, you can see that in the old days, the surgeon went from town to town to treat patients and receive money for it. If you can see it on the table, there is something like a diploma, which could be fake, but it would give the people trust. Now later on, all kinds of images were made. And back in Amsterdam, we have old dental chairs saved from being thrown away in a small museum. And you can see that behind the chair, you see a drill which doesn't work on electricity like this one. You have to step with your foot. So when we talk about the situation in Spain and Portugal yesterday, with all the electricity running out, a dentist could still work when he has kept the old apparatus. Now, the ADA is a European association. And if you look at the map of Europe, you can think that, well, dentists can cross borders to work in different countries when they have a legal diploma from one of the countries. But in reality, the map is more like this. A dentist in France will be trained a bit differently from the Netherlands. And a dentist from Greece will also be trained differently from someone from Poland, for instance. So the aim of the ADA is to commit to the advancement of the highest level of healthcare for all people with concern to oral health, and to promote advancement and foster convergence to high standards of dental education. So the main aim, in my view, is always to harmonize the dental curricula and to make sure that dentists from various countries have basically the same training, and so they can work in a reliable way. Also, oh, yeah, excuse me. Okay. If you have a question, you can ask a question, and otherwise you can do it after the presentation, okay? And also peer review and quality assurance in dental education is important. Many of the European dental schools are a member, and also Tehran University Dental School is a member. We focus on assessment and teaching methods, examination methods, and exchange of students and staff is very important. So we are more like a European link to other bodies, like the Platform for Better Oral Health in Europe also. We have quite a few members. 77 countries are joining the ADA worldwide, also outside of Europe. We have been to Tehran a few years ago. We were welcome to study the dental faculty in Tehran and write a report on it and give some recommendations, and it was a very warm welcome. Also, some institutions are members, like dental associations in certain countries, and we have a fee, and we have sponsorships from the industry to make it all possible. Now, we have a few key activities. The scientific meetings we have once a year. They are, we also had delegations from Tehran even last year when we were in Belgium. We very nice colleagues of yours, Puyan, were there, and it was very interesting to share our experiences. We do school visitations. I will talk about that a bit later. And we do all kinds of collaborative European activities. This is a picture of 2019 in front of your building. And this was in the Center 4, you could see the visiting team from ADE. And the dean you had was Professor Rocken. And I believe he's now succeeded by a new dean. But it was a very warm welcome and very good to be enabled to look in the kitchen, as we say. We could see how you organize and manage things, and it was very impressive. Now, we have developed from there, and we have now a program, a visitation program, which is called Leader. And on request, we can come to dental schools to do a visitation, talk with staff, talk with students, see the facilities, and write a report on it according to a certain formula. And in the report, you can see recommendations and strengths and weaknesses and possibilities and opportunities. And so we can try to think with the local dental school about how to go from here. And I think these initiatives are very, very valuable. We have also guidelines. These are written in the European Journal of Dental Education. And we started writing these profiles and competences for the graduating European dentist somewhere in the early 2000s. And it has developed into what we now call the graduating European dentist. And the last directions for that were from 2017, but things have moved on from then. And the graduating European dentist is a revision of the profile and competences of the European dentist. And the current version respects the previous work in style, format, and approach, and also adding considerably to the advancement looking into the future. You can easily see what the graduating European dentist contains by going to the ADA website. You can see it's ada.org. It's free to open. And if you look into the curriculum documents, you will see that the GED, as we call it, currently focuses on 5 domains in dental education: professionalism, safe and effective clinical practice, patient-centered care, dentistry and society, and research within dental education. And also we have guidelines for methods of teaching and assessment. And there's a curriculum library with documents that describe dental education fully. If you go to the website, you will also see this, this picture, and I cannot explain it all, but it's called O-Health Edu, Oral Health Education. And in it, you will see that certain topics, aspects of dental education are described. For instance, an integrated curriculum, and integrated means all departments within a dental school are encouraged to provide integrated dental care in their clinics. But integrated curriculum is also looking over the borders of dental education to health medicine, to oral hygienists, and others who are involved in the care of the patient. Now, one other thing to mention, and then I will stop for the moment, is there is also a dental student association, the European Dental Student Association, EDSA. They have a website too, and they are very active students from many, many countries, and also non-European students are always welcome to come to their meetings. They are encouraged to do so because they promote very much networking and collaboration by sharing experiences from various dental schools. From Amsterdam, always a couple of students go to their meetings, and they always come back very enthusiastic by learning how dental education takes place in other countries. So I suppose I will stop for the moment, and then later on in the meeting I can go into a question about how dentistry can be taught in future years. And I will stop sharing now.
Okay, thank you very much, Ronald, for your informative presentation. Let me start the discussion panel with a short question from you, and then I will ask the same question from other experts. The first one is, it seems that ADE is a consultation body. It is not accreditation body.
Yeah.
Do you recommend all dental institute or dental school to be under supervision of an accreditation body or regularly supervised by accreditation bodies to keep their quality, education quality, and improve their capabilities in dental education?
Mm-hmm. Yeah, it's clear that a school visit by ADA does not give accreditation. It is a visitation in which the many aspects of that particular dental school will be highlighted. In many countries, you need to have a formal accreditation, which is organized by the ministries of health or education. It's different in different countries, in order to have a legal diploma. So in a country like the Netherlands, we have a accreditation system which accreditates the 3 dental schools in the Netherlands. and 2 in Dutch-speaking Belgium. And only under a recent accreditation, which takes about 4 to 6 years, the diploma that a student receives gives the right to subscribe in the register as a dentist, because dentist is a professional, restricted profession, and you're only allowed to treat patients when you have a viable legal diploma. And in order to do so, you need formal accreditation. Now, there are countries in which this is organized in a different way. And so they do not have this same accreditation bodies. It's not the same in every country. But the school visitation by AD can help a school who aims to develop into a certain direction, because they can knock on the door of the Ministry of Health and say, this is our school visitation report, and we really underline what is said, and we need your help to move into that direction. So for that reason, it is accreditation is always necessary within countries that demand it, but the school visitation can be a step going to forward.
Okay, great. Professor Thananphum, could you please share your experience about accreditation in Thailand? Do you under supervision of Ministry of Health in your country, or you have another accreditation body in your region or in your country?
So overall, I think it's aligned with Professor Gorter that already mentions. It's by to legal system in Thailand. For example, all those dentists who want to have a license to practice in Thailand need to graduate from the accredited school. The accreditation body is Thai Dental Council. So each school have to submit documents and have a site visit from the dental association, Thai Dental Councils to approve or accredit that curriculum first in order to eligible to apply for the license exams. So that's a requirement by law. That is mandatory, meaning that every school in Thailand, if they want their student to sit on a license exam, so they have to pass accreditations. That's the first thing. And the other option, meaning that each school can seek out other accreditations. For example, in my school in Jular, we also seek out like other third body, for example, ANQA as accreditations of the educational system, or we can seek other international accreditation system. But that is not mandatory. If you want to improve your curriculum, your teaching, education, philosophy, I think accreditation somehow give you some feedback, whether how well you perform in terms of educations, giving the learning experience for the students. That is optional, but the basic mandatory, I think, is required by law that Thai Dental Council need to be accredit the curriculum in order to have eligibility to have the license right to do that. Yes.
Okay, great. Thank you for sharing your experience. And Professor Muneer, could you please let us know the accreditation in dental education? Please explain some details about accreditation of dental education curriculum in Malaysia.
Okay, so ours is quite similar through many other countries. So we have Malaysian Dental Council. So they give accreditation, but through Malaysian Qualification Agency. So we normally, Malaysian Qualification Agency makes standards for the whole country. Then they have specialty like dentistry separate, medicine is Malaysian Medical Council, we have Malaysian Dental Council. So they involve Malaysian Dental Council to come and do the site visit, check the records, all these things. So they have a point-based system. So all the quality indicators are there. Based on these quality indicators, like maximum now you can get up to 7 years of accreditation. So this is just recent. Before that, 5 year was the maximum. So then normally you submit all the evidences, the documents through their templates, and staff from Malaysian Qualification Agency, Malaysian Dental Council, They come and visit for 2 to 3 days, and they check everything. Based on that, they will give you the accreditation for next 5 year, 4 year, depends on how much score point-based system you have. So basically, the bigger umbrella is Malaysian Qualification Agency, which is for the whole country, but for dentistry is Malaysian Dental Council. We submit documents to Malaysian Qualification Agency, but they are basically submitted to Malaysian Dental Council. We have, because the national guidelines say that there are some indicators that we have to achieve, which are like the broader one, but dentistry is all Malaysian Dental Council. So we have recently a visit, which is normally 2 days. So the panel of assessor will go through records, site inspection, student interview, faculty interview, support staff interview. They go through a lot of records and a lot of triangulation is done. So it's a very stringent way of doing it, but the quality assurance is quite high. That's in Malaysia. Thank you.
And one quick question.
Yes.
Is there is it necessary to have international accreditation for a dental school in Malaysia or not?
We have, because our IMU, my university, we are very unique. We have a partner dental school program. So we have our student halfway through, like end of semester 5, they will go to partner school in UK, which is Glasgow, Dundee, and Liverpool. Or in Australia, they go to Adelaide. New Zealand, they go to Otago. Or Canada, they go to Dalhousie. So they will graduate from there. So we have credit transfer for our university. For generally, we don't have the international, but it is up to the university schools if they want. Like we have the CAD visitation, just like the AME one, we have the AD one, we have the CAD. So they, a few years back, they visited us and they have their quality indicators, and they did almost the same like how Malaysian Dental Council would do. So that is one. In fact, if the schools want, they can go for international like visitation or accreditation if they want, like from General Dental Council, UK, or Australian Dental Council.
Okay, great. Thank you. And
Welcome.
Professor Mirzazadeh, I well know that you have been pioneer in accreditation of medical education curriculum in the Ministry of Health for several years. Could you please compare the accreditation of medical education curriculum regarding international accreditation bodies and national accreditation bodies? And I will be grateful if you would share your experiences with us about how authorities of dental school or medical schools can follow can try to accredit their curriculum or their dental schools.
Yes, thank you. Thank you for inviting me, and thank you for sharing great issues with other colleagues from Thailand, from Malaysia, and also from Netherlands, and especially from European context. Just for the sake of time, I prefer to summarize and say that exactly the same situation in comparison with Thailand and also with Malaysian experience. We have the same situation. We have a dental council, dental education council under the umbrella of the Ministry of Health and Medical Education. As you know, that the health and medical education in our country is integrated, and therefore we have a council over there, and there is regular visits from dental colleges and also medical colleges in the country, because the same situation, we have a council for medical programs and medical education programs. You talk about the MD program accreditation. As you know, we have for nearly 20 years efforts to establish an accreditation system. And finally, in 2019, in 2018, we applied for WEFMI recognition of our accreditation process. It's so important that to the best of my knowledge, we don't have any international accreditation of medical programs in any country. And there is just a recognition for accreditation bodies of medical programs. And it comes currently, and usually it comes from WEFMI, What's Duration for Medical Education, that provide a recognition program that based on it, every accreditation system for MD program, we should be reviewed by certain criteria that have been set by the WEFMI. And if the accreditation system achieve those criteria, then the WEFMI provided a recognition status to that accreditation system. It doesn't mean that WEFMI accredit the programs under that national accreditation agency, but it means to some sort WEFMI could ensure that there is a quality assurance process in that country or in that region. And we received it in 2019 for a 10-year period. About the accreditation of dental education, as I mentioned, we have the same system, but there is an issue that I would like to ask my colleagues, for example, from Malaysia or from Thailand, that usually the accreditation system exists, but for example, the robustness of standards or comprehensiveness or following the current trends in, for example, medical education. There is some debate about the performance of the accreditation systems. Somehow, I'm not sure that I understood well or not. Sometimes in some accreditation bodies, the standards are more focused on numbers and quantities, and there is a overemphasis on quantitative aspects or transforming any quality to a number. And just by summing up some numbers, they reach to a decision. And in my understanding of accreditation during the last 30 years, it's much in contrast to the underpinning principle of accreditation that is more qualitative and constructivist approach to program evaluation. Therefore, in brief, we have the same situation as our colleagues in other countries or other regions. We did something for medical education to be strive against international recognition criteria, but we are my colleagues in Dental Education Council are going to improve the situation.
Okay, great. Thank you for sharing your experience with us. And Amirhosein, I think it's time to share the questions of our participants with the professors. I suggest to start it with Professor Mirzazadeh. Are you still with us, Professor? And I will be grateful if other experts share their ideas on these questions. Amirhosein, and also Amirhosein, please share the question after asking it from the expert. Share it in the chat box, and then participants can read it in chat box.
Yes, for sure. Before we start the questions, I'd like to kindly ask all participants to send their questions through the chat and also make their names in the right way in which we can send them the right certificates. So we start the questions. So the first question for Dr. Mirzazadeh, what soft skills do you see lacking in today's dental graduates, and how can we improve on them as students?
By the way, before you join the meeting, Professor Mirzazadeh, I explained for the participants that you are physician, you are well experienced in medical education. Therefore, I would like to a little bit change in the question and ask you again, what soft skills do you think is necessary for medical or dental education that the authorities or executive or educational boards of the schools of university should include in the curriculum?
Yes, thank you. Great question, and there is some debates about it, and I'm sure that colleagues in the panel have interesting point of views to my introductory talk. But the first issue is that, and the first challenge is that, what is the soft skills? And there is not a clear line between, as we called it, hard skills, that it's somehow related to any specific disciplines, and soft skills. And therefore, some people believe that, for example, some people believe that clinical decision making for a physician is not soft skill, because it's inherent in the practice of medicine, and therefore it should be considered for. On the other side, some people believe that soft skills means that they are not core, they are not so important as hard skills originally. And because soft skills came from military service and military training, and at the time they decided to say something as soft skills rather than more transferable, more general aspects. But with developments in medical education, some people believe that the most important aspects of any discipline is not at the same time as the expertise in any specific field, psychomotor or knowledge aspects. You need more than before what we called it soft skills. Yes, and therefore there isn't any global or consensus on what is the meaning of soft skills. But honestly, we had lots of soft skills that our curricula are deficient or not just lacking, but sometimes we have something but is not quite enough to for example, as we could see the patient-centered care that Professor Gorter talked about it, or dentists in society, means that you need to communicate well with patient and also with community. You should have emotional intelligence that could understand yourself and to manage yourself, because the current situation led to lots of burden on professionals. And as Professor Gorter talked about the burnout and how we could prevent it, sometimes we need some skills that help and assist physicians or dentists to cope with such situation. And we tried just in our MD curriculum revision, somehow, I'm not sure that I'm precise, but somehow for the first time we clearly defined these skills rather than just medical knowledge or procedural skills or history taking or physical exam. We add officially these items in our, for example, personal development and communication skills, professionalism in our curriculum, at least the framework of competency framework, and then we try to implement it in our program gradually, and then we move to the national level, and in the last version and edition of our curriculum, we add these items and these issues to the curriculum. But the major challenge is implementation, and to how we could cope with hidden curriculum that exists in practice, as you could see behind the Professor Gorter a clinic. And what is happening over there? I'm sure that it's pretty nice over there, not just the building, but the practice of physician in Netherlands. We should be concerned about what is happening on the ground and what our faculty members play as role model for our students, and if they practice is in contrast to what we are telling the students in our classes or in our workshops, this dissonance is so hurtful and should be managed. And in brief, we added some soft skills to the curriculum. We emphasize it, and we believe that they are not extracurricular. They are intracurricular and some of the most important aspects of the curriculum. And we try to transfer these skills, but we believe that we have lots of challenges to implement in practice to transfer our students to those practitioners or professionals that perform well in these aspects. Thank you.
Mhm. Thank you, Professor. Due to importance of this topic, I would like to invite other experts to share their ideas. I would like to share the Iranian experience in our dental schools. We have limited curriculum based soft skill program, for example, for communication skills. However, most of the soft skills are extracurricular programs. For example, workshop or something like this have been designed for this soft skills. Professor Muneer, could you please share your experience in Malaysia? How do you highlight soft skills in your dental school?
Yes, this is, I think, one of the very important aspect of it. There are many reasons. One, as noted earlier, I also do research on empathy. So from there, we derive so many things. So in our curriculum here, from semester 1 to semester 10, we have module called Clinical Humanities and Well-being. So in clinical humanities, we start from like transition to the university, because the student before university, they learn differently. They think, do things differently. But here there are patient, there are a lot of things are changed. So from that, we in this course, we teach first in the second semester, like teamwork, team building, team formation, how to work in a team, because dentistry is all interprofessional education, so many things, even to communicate with the lab, with the nurse. It's sometimes the young student find it quite difficult. Then we have law, and then semester 4 is all communication skills. 5 is clinical reasoning. So like until semester 10, we have every semester a theme. So with that, we have something called professional practice assessment, PPA. So in that, the students are assessed by the nurses, by peers, themselves, by lecturers and patients. So we collect information about the students, almost all students in the cohort. Different cohorts, the different semester coordinators are responsible for it. Then we have a student progress monitoring committee, in which we have, because PPA we have is, since it's a 360-degree evaluation, so we have something very, I think It's very significant. We have concern note, but we have also praise cards. We just don't say that, okay, you have done something wrong. If they have done something good, we give praise cards also. How it works is like, for example, if student is late or some patient issue, so the lecturer, nurse, or peer, they can issue a concern note. So it's an orange color card, so they will receive. So if they receive 3 concern notes, then they have to see the dean or program director to sort out things that maybe there is something people have not understood. So to cancel the concern card, they have to do something nice to get a praise card. So when they get a praise card, their concern note automatically will cancel. So that's how when they start, they get 20 points already. But when they graduate, they should have 20 points. So in between, things will happen. So that has helped us quite significantly to understand how students work. Then from our definition of soft skill is they are essential skills. Because from my research, and I think most of the research, even you read, so they say the devil is in the 3rd year, because when most of the students go to the clinicals. So I normally, I presented that the clinical suddenly becomes cynical, because we emphasize so much, these are the requirements, this is the assessment, the students are so driven to get complete, like they complete these requirement and assessment that they forget about that they're supposed to be a doctor, they're supposed to help. So that is one thing that we are working on it, that we keep on reminding them. In fact, one of my paper, which was on patient perception. So most of the patient, when we interviewed them, we collected data, they say the same thing. The junior students, because they were very idealistic, very nice, they are very empathic. When after halfway through the curriculum, something happens to the student. Even some of the patients said that they become robots. They just want to, take history, drill, fill, and bill, because they have to complete requirements. That's why it's something like very important. Then we started to assess them in our OSCE exam. But OSCE exam, we found out that there's something in them, because that time they are stressed out. So it can, I'm just giving an example of empathy. So previously we thought it no empathy or empathy. But then we found out that there's something called detached concern. They are concerned, but they are more concerned about their exam. So they are there because some of the simulated patient or actors or real patients say that they were faking empathy. They were not concerned about me, but they were showing it off. So that was the detached concern. So the idea is, since they are essential skills, and skills, anything we call skill, they need practice. If we don't practice it, we'll forget about it. So that's why our whole curriculum have like parallel. There may be different modules changing, but this module remains from 1 to semester 10. We teach them everything that include dental practice management and entrepreneurship. So we try to be like the basic concept is, let's make doctors human again.
Great, thank
So,
you. I will be back to you because you well mentioned about the assessment. I think the assessment
Yes.
of this skills is very important, and I will be
Yes.
back to you. Thank you.
Sure.
Professor Mirzazadeh sent a message. Let's ask the same question from Professor Thananphum, and we will back to your comment about ethical erosion. Professor Thananphum, could you please share your experience in Thailand? Do you highlight indirect and direct soft skill improvement? You know, sometimes it is necessary to indirectly improve soft skills in your students. How do you think about it?
Yeah, thank you very much. Indeed, I agree with what Professor mentioned about the soft skill before. And our school has been implement how to teach soft skills in, I think, 2009, that we developed curriculum into competency-based curriculum at that time. So what I agree with Professor Azim that the soft skill word is very difficult to define what is soft skill that you want to teach to students. So what we do is we do stakeholder survey. So we survey employers, all those in ministry or in the clinic. We also survey graduates and survey nurse and also faculty member to identify which is a soft skill that we want to implement into our curriculum. So when we gathering all the data from all those stakeholders, we divide up into 3 main categories: hand, head, and heart. Meaning that hand is, for example, communication skill. We think it's a hand, so you can just like it's the skill that you can practice. The other thing is head is about like, for example, critical thinking, creative thinking, and the heart is maybe something empathy, for example. So we divide into 3 categories, and we try to arrange the learning experience. So meaning that we don't want them to have this kind of teaching by chance. Like, let's say if they go to the clinic and then there's meet supervisor that can be a role model for this soft skill, that's a good chance for them. But in terms of our design curriculum, we do not want that to happen. We want to have all the students have the same learning experience. So we develop all the skill into smaller tasks. Then we divide into 6 years. So each year we have the subject so-called professional development. So we implement all these soft skills into this course, and we align it from first year until 6th year. So all the hand, head, heart that we divided, we list the skill and then we implement it in each step. For example, the first year student, they will be exposed to very easy communication just to have the effective communication in daily life. When they move up to like clinical year, like 4 year, the 4th year, 5th year, they have to start develop the skill of communication in terms of patient communication or patient education communication, for example. So the level of skill that we want to implement, it's incremental by time, depends on which they export in that year. For example, that the communication may be very easy to do it because you have a little bit easy to chop down and then finalize for each year. The other skill, for example, empathy or how to say the ethics, it's quite difficult a little bit, but we try to again chop down. For example, empathy for the first year maybe like in general empathy, like when you saw people fall down, when you do something like that. But when you move to the clinic, then empathy is more focused on patients. Did you look them as a whole, not only the health, but also the community they stay in, something like that. So it's kind of like a chopping down each skill to implement in each year. That's what we do. For the assessment, it's quite difficult. I think I also learned from Professor Muneer a little bit about how to use the card. That's very nice idea. We can implement it in our school as well. But it's very difficult because, for example, ethical aspect of the soft skill, you cannot access how the ethic. You can set up the situations scenario to test them, but that can be fake or can be adapt according to what they expect us to see, because it's setting up, even though in the clinical treatment, in authentic assessment as well, but it's quite difficult. So in terms of that kind of aspect, we have to develop a quite nice tool to do it. But right now, I think we do the same. So if they not do something unethical, we just assume that they have ethics, something like that. But for the other communication skill or other soft skill, creative thinking, critical thinking, we have a rubric to evaluate in each situation. In the clinic, in spite of evaluation of the skill in that particular session, for example, when they do to the treat in operative sessions, despite only the checklists for operative procedures, they can have other evaluation sheet for soft skill, for example, like do they communicate properly? Do they have a good manner to the patients? Do they properly contact with the nurse or assistants or supervisor? So that is got another sheet to pick. And we collect all this and give back to the student, whether some kind of formative feedback so they can know what they behave. And if they want to improve, then we try to find another way to help them. That's a thing that we done here in Jula for now. But it developed since 2009, and then it keep changing all the time because this one is very dynamic. How to access soft skill is very difficult to do so, but we try to give them experience and also how to access them properly.
Exactly. And then again, assessment is very important, it seems. Professor Mirzazadeh, what's your concerns about ethical erosion? Could you please let us know?
I just tried to figure out my understanding about the Japanese in the third year. We have the same experience in medical students that as Professor Muneer talked about, the junior students are more similar, much more similar to the patient and feel like the patient. And then they strive through their career as a profession. They fortunately or unfortunately, somehow fortunately and sometimes somehow unfortunately, become more similar and identical to the profession. And therefore, they are somehow far from patients. And we called it ethical erosion. It means that during the clinical practice, they lose some of the characteristics and those behaviors and feelings that is much more necessary for a patient-centered care. And we called it ethical erosion just to figure out what's my understanding about the
Okay, thank you for mentioning this term. And Professor Gorter, could you please share European experience about teaching and assessing soft skills? I think you have good experience in Akta University, especially in the Netherlands.
Yeah, thank you. I've heard very, very wise comments from our fellow panel members, and I fully agree with Professor Mirzazadeh that I would never call it soft skill. I think professional behavior, including proper communication, is a core of clinical behavior, and the perception of the patient of a dental treatment is very, very much influenced by the perception of how questions were answered, were you put at ease in the dental chair, could you communicate, did the dentist help you with the right expectations of the treatment? So that very much influences satisfaction with treatment. There are studies I read about, for instance, satisfaction with a denture. They are not so much determined by the technical qualities of the denture, but by the way the dentist was perceived by the patient in communicative behavior and attitude. And so these are figures that will tell you that all these things that we talk about are very much the core of our clinical activities. I like the example from Malaysia with the cards, which you reward the student for good behavior. And it's like a calculation to receive enough good cards, which is very, very nice. I never heard about that, but I will think about it. We, from the teacher perspective, we often are faced with the difficulty of the dental teacher to comment to a student who should change a bit in his or her behavior, because it takes time and it can be a bit emotional also to have a working relation as a teacher with your student. You're not only assessing the student, but you're also the coach of the student to help the student come and reach a professional level. And then when you have to really tell a student about misbehavior or things should change, you can get confronted with a reaction which costs time, which you don't have as a teacher. So this dilemma is also within medical education and within dental education. It's mentioned by most all teachers. So, and what we did at ACTA to try to intervene here is we have a committee called Professional Behavior Committee. I'm the chair of it. And if a teacher has difficulty with a student, he or she can be sent to the Professional Behavior Committee. And we talk with the student and we say, we're not punishing you, but we are here to see how you can gain the trust of your teacher again and what is needed for that. So we ask reflection by the students, and we give feedback to the student, and sometimes we have a little program that the student can follow in order to go back and work under the trust of the teacher. And at the clinic, every session, clinical session with patients, will end with a reflection by the students and feedback from the teacher, not only on the manual technical skills, but also on professional behavior, including communication. So direct feedback is very important to deliver to the students in order to, well, we see it as coaching. We are here to help you become a professional, and you may make mistakes, but we want you to learn from it. We're not punishing you, but we're helping you stand upright and continue from where you are. If you don't learn from it, then we have a problem. If you make the same mistakes again and again, then we seriously question your ability to become a professional. But I wished we had more time for communication skills training and all these not so soft skills. We always lack time. We include it in our curriculum, but I wished we had many more hours for that.
Great, thank you. Very well explained terms that coaching instead of teaching and assessing for the students. I remember that when you come to our school and evaluate our process and give a report, you gave a report to us. One of our weaknesses was too much assessments. You explained to us there is no, it is not necessary to assess the students all week, all month, and it is not necessary. You ask us to follow the improvement process of the students, and I remember this recommendation from ADEE. And regarding your explanation, I would like Amirhosein to ask the first question from Professor Muneer about the assessment. Could you please share the question with him, Amirhosein?
Yes, for sure. The first question for Dr. Muneer Babar. Are traditional written exams still the main way to evaluate dental students, or are new, more practical methods becoming more important?
And also, I would like to add a comment that I will be grateful if you explain briefly your assessment method in your school, in preclinical and clinical, part.
Okay, I think assessment, it all depends on our objectives also, the learning outcomes and how we, at which level, like we use Bloom's. So in fact, a few years back, I was doing a document creating example for my colleagues, like faculty, that if you are asking a question at C1 level, like single best answer, so how it look like, and if you are asking C6 level, so what is the difference between it? So because this is something we forget about it, and then the student go through a lot of trouble. So looking at these, like we in our school, we have one best answer or single best answer. We have short essay question, modified essay question, OSCE, OSPE. The other thing we started using since 2021 is interestable professional activities, EPAs. We have embedded this in the curriculum, which is quite time intensive, like just now mentioned. it takes a lot of time. People were very unhappy, but finally we have started doing it. So these things are like some kind of the other thing we have a continuous assessment. We have like a professional exam, but they are the percentage we have reduced, and we have more continuous assessment. So in a semester there will be 2-3 assessment like for that particular module, which carry marks to the final professional. So the things that happen is now students are a bit relaxed, because instead of big bang exams, they have like checkpoints or continuous assessment. So they know their progress, and they also know that they have to score here. So they will have not to worry in their final professional exam or the professional exam. So I think for the traditional exams like OSCE, it's very valid, still valid, but the rubrics are very important for each question, how you want to evaluate the student on what are the things. Like I gave example previously, we were doing for empathy, when the student introduced themselves to a simulated patient. So there were two options, no empathy or empathy. So then when we interviewed the simulated patient and the real patient, we found out that the detached concern is there. Like they call it faking empathy. They were not empathic, but because of the exam stress, they were doing it. So I think OSCE exam, objective structured clinical exam, they are very valid. And like in dentistry context is very, because ours is mostly skill based. So that I think, and then portfolios are very important. Portfolio based assessment. EPAs, which we are doing, is work-based assessment, and now a lot of things on technology-enhanced assessment. So in that, we are doing things I wish we can start the adaptive assessment, but that is so expensive to have it. I think I know there is only one organization, the Australian Dental Council, have it. But the initial cost was so high, like $2 million, to even create that whole thing. So coming back to the question, OSCE, portfolio-based assessment, workplace-based assessment, these are the traditional and these are still very valid. On top of it, we can add more things. Students are asking more quiz question. And the one thing I've recently learned, as you might know from my from LinkedIn, I do a lot of AI things. So I always sit with students, ask them question off the record, that what are the things you do? Because recently there is a trend that they are asking all our PowerPoint slides. So I was like quite amazed suddenly what happened. And they want every slide. Like normally I will change few slides on the day of presentation because we have a e-learning portal. LLM is there, so everything is there. But they wanted particular everything. Then I asked few students, so the AI, they have integrated it. So they upload our lecture to different AI tools and ask AI to create one best answer question, SEQ or SAQ questions. So then they attempt it as a formative assessment for themselves. So they learn like this. So I think with all these things, traditional assessment still valid because the new technology is all digital. It's still, we are in most of the places, it's still in the development stage. AI is a new thing, but AI is moving too fast and we have to do a lot of catching up. So finally, I think we are not have it like yes, but we are trying to get a system in which we can track a student progress from when they join us until graduation. So it's an AI-based thing, so it tracks a lot of things. But the customization, the company was not able to do what we were asking, so many customization. So these are like, in the new technology, these are the limitation because the companies, they create a very standard thing. And for us, like when we were acquiring haptics for our simulation center, so most of the companies who provide haptics, they were only provided that these are the templates and you have to use. So we wanted customized. Then finally, we found a company who customized all the assessment in haptics for us, and students are enjoying it. So this is the future. We have to go in that way. But currently, as I mentioned, all the traditional assessment methods are still valid and they are still good.
Great. Thank you for sharing your experience. And I would like to ask Professor Thananphum this question and another question. Amirhosein, would you please share this question from our audience about clinical feedback? And I would like to share it with Professor Thananphum.
Yes, for sure. Dr. Thananphum Osathanon, how can we learn from our exam and clinical feedback to improve instead of just focusing on passing?
Do you routinely feedback to your students after any exams or not?
There are so many ways of feedback. I mean, not only verbal feedback. If you give some score to them, it's already considered feedback as well. It depends on the objective. So let's go back to the first question that Professor Muneer did respond first. I also agree with his response. I mean, it depends. The assessments depends on the objective of the thing you want to evaluate. If you want to evaluate the knowledge, of course, written exam would be the good option, so the best option for that. But if you want to evaluate the skill, you want to evaluate the ethical concern, there are other kinds of evaluation methods that can be used, not only written exams. And those exams or assessment need to be directly answer what the objective of that particular evaluation. For example, you want to see whether they have competence to perform classroom preparation. You not use written exam to evaluate it. You maybe have to ask them to perform in mannequin or perform in patients, and you have some kind of checklist or rubric to evaluate that. I think so. It may be good in some certain application if it answers the objective of that learning experience, but if it not, then it will not suit. So we have so many kinds of other tools that can be fit in particular objective. That would my response for the first question, meaning that written exam is still valid in some context, but it's not can be used in all situations that we teach or provide learning experience to the students. For the second things, the feedback to the student and how can to make them not only focusing on passing the exam, for example. I would think that we have to go back to the objective of assessment first. I think we have three kinds of assessment to be aware of: assessment of learning, assessment for learning, and assessment as learning. So what in the traditional way in the old day that we do is only assessment of learning. So when we teach for a certain chapter and then we have the exam to evaluate whether how they know, how they learn, how good they are in that subject. It's how to differentiate the students. So that is a assessment of learning. But in the way to help them improve their performance in the next step, you have to give feedback to them. So that's fall into assessment for learning. So you give feedback just simply by just giving a score to them. They know what they performed in previous exams, so they can prepare themselves for the next exam. I think that considered already as a formative assessment. So you give some information back to the student. They know what their situation is, and then they improve themselves. Or in a complex way, like in a clinical setting, after you finish the clinical exam, each sessions with the patients, they have some small session with the supervisor in that particular period, and they review what they have done. They go to the score sheet together. What the procedure that you have done good? What is the behavior that you done good? Communications, manner, or other skill. So students get what they do best in that situations in that period, and also what they need to be improved that they lack in that period. So in next period, they know what they have to improve. That also considered as for learning. But the last one that we try to implement is assessment as learning, meaning that instead of advisor or supervisor tell them what they lack or what they're good or what they need to be improved, but they have to self-reflect themselves. We do this by like let them evaluate themselves first. After finish the critical sessions, they have to give the score for themselves by themselves. They have to think what they have done in these sessions. What is this one? Do they do good or not good? And after they evaluate themselves, they have some time to reflect what they have done. So it's kind of like from the inner, from themselves, not by other people to tell them. And then add up with the assessment for learning by supervisor. Together, they get some topic or then the issue or the thing that needs to be improved. So this is going to be much stronger than just tell them that they're good or not good in something, because it's come from their inner. So they may be eager to learn, that they know themselves that they lack in this experience, they lack in this knowledge, or they lack in this skill. So it's going to be motivation more to learn how to improve themselves in the future. So I think this, if we set up this kind of understanding to students that we will assessment you for learning, we will assessment you of learning, or we assessment you as learning in each particular sessions, then they will not have that much stress and they know what to do in the next one. Instead of just only do the exams and then eat up all the knowledge and vomit it out after finish their sessions. So they know what to keep up and then further improve in the future. That's what I think it needs communication from faculty member to the student, that what is the purpose of this assessment first, so then they can use the objective properly for that.
Great. Thank you. It means that assessment is a very important feedback, is very important part of teaching to the students. Amirhosein, please accept my apologies because I have a personal question. And I would like to share it with the experts about integration of basic sciences into clinical dentistry or clinical medicine. You know, it's a great topic. You didn't include it in your questions from the participants. However, it's my great concern, because I'm an oral pathologist and I would like to share it with the Professor Gorter. If you have any comment about feedback or assessment, please share with us. And after that, I will be grateful if you would let me know about the integration. Oh, Professor Mirzazadeh, do you have any comment?
No, after Professor Gorter about the issue of assessment. After.
Oh. Okay. Professor Gorter, please share your ideas about assessment and feedback. And after that, please open the next question about integration of basic sciences into clinical dentistry. Is it important to be highlighted in curriculum and in the dental education or not?
Thank you, Puyan.
Welcome.
I will try to answer these questions. I hope there's not too much noise. I will close the window because there's some workers out on the street.
Okay, no problem.
So maybe this will help. Well, assessments, we do assess, of course. We have examinations and tests and things, but not too many indeed. So the best way to assess, I think, is when a student also assesses him or herself, and by daily asking questions, what I did and what went wrong, why did it go wrong? So including in the daily reflection should be the clinical reasoning of the students about why things didn't go the way that they should go. And also in a positive way, why did things go well this time, which didn't go well previously? So the active clinical thinking by the student is very important, rather than asking the teacher, how can I do this? So that's a major thing to develop into a independent professional. So any learning condition should allow the students to do this creative thinking. And the example of the entrustable professional activities that was mentioned from Professor Muneer, they are an important tool in this, because they force the student to think critically and also receive the feedback from the teacher at the same time. So these assessments, I think, are very much important, although they are not like a one-moment assessment for which you pass or fail. We have them too. For instance, we have an OSCE setup in which junior students are required to show certain skills within a limited time. And for that, you can pass or fail. And if you fail, you are given the chance to do it again and be better prepared. Yeah, so that assessment is often preferred like programmatic assessment, which is called in medicine, by which you offer the students moments of assessments which are not decisive for continuation of that certain part of education. But it's like monitoring yourself and seeing that you're on the right way, or that you may have to strengthen certain aspects of that education. So that programmatic assessment, I think, is very helpful in having the student grow up to the level of a professional. Now, with regards to basic sciences, I think it's always preferable to learn within the context. So if you teach basic sciences, it is most helpful for the student when he or she can adapt this knowledge into the real work situation. So if it's, I don't know, some dental schools, they have like 2 theoretical years before students enter clinic, which can be good because you get training, you get a lot of knowledge and a lot of experience in certain things. At our dental school, we are trying to get the student into the clinical situation as early as can be. So already in the second year, they assist in clinical treatments with elderly years. And by doing so, they can see why they do need biology or chemistry, or because they see the materials that are used. In order to know how to use them, you need this background, you need these basic sciences, because it is visible in the clinical situation and you have to have this knowledge. So that's the way we try to offer a context-rich situation in which the students can learn also basic sciences. So yes, we do try to connect it as much as possible to the clinical situation that the student will enter.
Okay, great. And which level of integration, Professor Gorter, do you recommend to the authorities of the dental school or your universities? Is teaching various teachers, professors from different departments is enough for integration, for the integrated teaching method, or this is the lowest level of the integration, and we need to improve our school to a higher level of integration in teaching medical sciences?
Well, some years ago, already quite a few years, we had the students go to the endodontics clinic and go to the periodontics clinic and go to the cariodontic clinic. And they became good professionals. Of course, they learned a lot from those places. Some years ago, my predecessor as director of education said, well, we want to create a situation during education that resembles the practical situation after graduation as much as possible. So in your dental practice, you don't get just endodontics or periodontics, but you get a new patient and you have to examine the patient and see what is needed for this patient in the whole width of dentistry. So we have now an integrated clinics in which patients are allowed to come when their situation is right for the dental students to learn from. And we have our staff, dental staff from various departments, endodontics, periodontics, and they can supervise. And if a patient situation is quite complicated, then the staff member will be like a consultant to the dental teacher, the general dental teacher who is at the clinic floor, in order to, and when the patient is a bit too difficult for student treatment, they are referred to the specialist clinics, where endodontics are trained after graduation, of course. And then, so that's the situation. And so the whole clinical floor is more like you get a new patient and you're exploring what is needed. And if the problem is mainly perio with you know, life habits changes, etc., then the consultation comes from that direction. So again, it is aiming for the actual situation after graduation, which does not say that departmental clinics that students do not learn from there. Of course, they learn so much, but we try to change the setting a little bit.
Great, great. Thank you very much. Professor Mirzazadeh, do you have any comment on?
Just to add something to my colleagues talk about the assessment. As I might remember, you talked at first about, in your question about assessment, you talked about the assessment tools. And this is the real practice when we were talking about assessment traditionally. We are more focused on tools, and we think more about what tools we should use. And as Professor Thananphum talked about, it's dependent on our objectives. And the second challenge raised when we think about objectives and competencies, and it means that most of the objectives are disintegrated and fragmented. Something about knowledge, something about psychomotor skills, and something about attributes. And in real practice, we ask dentists or physicians to do something. And it includes some aspects of knowledge and some aspects of skills and some aspects of attitudes. And therefore, this theoretical and arbitrary division between different items led to lots of numbers of objectives that is impossible to assess meaningfully. And therefore, we have a movement toward competency and competency-based education and competency-based assessment. Therefore, as I understand, we should move from focusing on assessment tools toward what we should assess. And we should assess lots of things. And then we need some sort of matrix that for which competency we need to use which assessment tools. And as Professor Muneer talked about the triangulation, sometimes and usually we need to assess some competency with more than one tools to ensure that the quality of assessment is enough. You talk about your memory of the Gorter visit and that assessment number is high. I believe that the major challenge is not about the number of assessments. It's about the major use of assessment. If you use assessment just for pass and fail, when you use it lots of times, it could lead to fragmentation and also to burnout and frustration. The students need lots of assessment, but not assessment of learning, but for assessment for learning. And it means that they need to be assessed and to receive feedback. When I for the first time when we tried to implement it in our residency programs, after lots of talk, we had a written examination for our residents, MCQs. And when we were preparing for that exam, the directors, program directors asked me, what's the minimum pass level of this exam? And I told them that in our current situation, in new assessment system that we are going to implement, we are not going to put minimum pass levels for each assessment. But we need to provide feedback based on this assessment to the residents. If we have an OSCE examination, that OSCE examination is not going to pass or fail the students. It should show them and it should provide them with feedback, what is happening right and what is happening wrong in their practice. But in one point, in this trajectory, you need to come to a decision, as Professor Muneer taught, Professor Gorter. We need some point to decide that this student is not capable to go further, but it not should be so high. Not minimal assessment, but all of them are high stake, and it's not so good. Yes, and that is the reason that we are going toward programmatic assessment for learning, mainly assessment. Not it has changed that we are not using low stake, but for a better understanding, low stake examination for providing feedback, for collection of data from different sources, and mapping it based on the competencies. And as Professor Muneer talked about, a tracking system, that you could track every activity of students based on your competency framework from the first day to the end of the education, and to provide a clear picture of what's the practice of that student, for example, during the last year, and the promotion committee then should decide about what we should do with this student after lots of feedback for improvement of that student. Thank you.
Great comment. And I was thinking that for this great purpose, we need well-trained, enthusiastic, energetic, and also engaged, committed faculty members. And it is very important to have the faculty members for this purpose. Thank you, Professor. We have just 2 to 3 minutes to wrap up this session. Therefore, I would like to share the question with Professor Muneer and Professor Thananphum about integration of basic sciences into clinical dentistry. Please share your experience in your dental school and let us know about your thoughts on this topic. Professor Muneer, please.
Okay, so I think when this topic came, I really liked it because what we have done is by design, we have done a lot of things. So which were initially our students have the same concern, why I'm studying medicine, part of medicine, why? Because I'm supposed to be a dentist. So the first thing we changed was the curriculum. So we have something called team-based integrated learning, in which one clinician and one basic scientist, they have a presentation, 20 minutes. Then we give a task, different clinical scenario tasks to the students to discuss, and then they present for 10 minutes. So each class have 5 groups. So that's how we integrated the clinical and the basic sciences. The other very major thing we have done is we don't have Department of Perio, Department of Indo, all gone. We have clinical oral health sciences division, and we have the clinical division. There are 2, and we have integrated, like in these 2 divisions, all the departments. So nobody can call that I'm from Perio department. The other very important thing, our clinic, just like in Netherlands, we have integrated clinic. So our faculty duties are based on that. Like every session, clinical session, have one periodontist or two periodontists, two endodontists. They are on the floor. So, and the student have to manage the patient for everything. It's not that for scaling and polishing you go there, for filling you go there, for extraction there. No, everything by one student on one floor in one area. So that is one thing, like three major thing that has happened: the curriculum, the mindset, means the divisions we have made, the instead of departments, and the clinic. So it helps us a lot. And the students they are no more commenting that why I'm learning this. And one thing we have started 3-4 years back is group dental practice. So it is for authentic learning. So the senior students are the owner of a group, and junior students are associates. So they have to manage. So they give their clinics their names, and they practice like normal clinic. So there are few sessions like this to give them that authentic experience, that how real life would be. Because in university, it's an ideal world, everything is fantastic. But once they graduate, the world is upside down. And 50% of they have learned is already obsolete. So we want to make them future ready. So that is, and students really love the group practice sessions. Yeah, thank you.
Thank you very much for your explanation. And Professor Thananphum, could you please share your experience with us on integration of basic sciences? You know, I am oral pathologist, and I'm very interested to learn your experience about it, because some credits, including oral pathology, are very boring for the students. When you teach this credit separately from the clinical, you know, purposes. Please explain your experience.
Thank you so much. I'm from anatomy as well, so I'm basic science.
Oh, great, great.
Sorry, it's thunderstorm outside here, so it's going to be noisy a little bit. Sorry about that. So the thing is that we first need to make the basic science more interesting to the student first. So they need to be engaged to the basic science. What we do here in our school is we're not teaching by discipline anymore. So we don't have all of pathology, we don't have anatomy, we don't have physiology, but we accumulate as a theme. For example, human body, abnormalities, and then everyone in both clinical department and basic science department, they teach together in that subject. So they're gonna have the, like, let's say the case from clinic, that might be the beginning of the thing. So that even though the basic science student, I mean the preclinical students, they have some experience from what the clinical would see in the clinic first, and then we link that back to like what anatomy should be, what physiology may be related to that system, or what abnormality and pathology going to be related to that system. So in this way, student is more interesting to learn than just starting by first topic, part anatomy, second is GI anatomy. That's going to be a little bit boring, and also they not know how to adapt into clinical situations. So if we turn around a little bit, invite some clinical faculty member to join, and then they start with some interesting case, then it's more eager to learn, and then maybe so they can see what link between basic science and clinical. That is how we arrange the curriculum for the preclinical years. For clinical year, right now we have the subject so-called integrated oral biology into clinical. So meaning that we're not teaching them basic science during their skill practice in the sessions. They do what they need to do in the clinical section, but we have the case from the clinical section into this subject. And then we discuss deep into basic science. For example, endodontic, they do in their practice as like procedure for root canal treatment, but they use that case back to this subject. And then we start to discuss back to the basic science. For example, anatomy of root canal, why they see the radiolucent in this lateral area instead of radicular area, or what is the pathology of radicular area. So it's kind of like a remind or review a little bit, and also link to what the case that they've done in the clinic. So this is kind of like a, how to say, not really teach them during clinical session, but use a clinical case and then make it reveal what they have learned in pre-clinical year in the clinical year. I think that this is going to be give more attention. I mean, students would like to eager to learn because that case they want to see how to relate it to mechanisms or like related to the basic science, anatomy or physiology that be related to that particular case in the same time that they do procedure in the clinic, but in different sessions. So what we do here in our school is like that. Yeah.
Great. Thank you very much. I would like to express my sincere appreciation to all of you professors for sharing your knowledge and time generously with all of us. I have to wrap up the session now, and I'm very hopeful to be in touch with you all to perform more educational or research project on these educational topics. And I would like to ask Amirhosein to share the certificates of appreciation.
Yes, on behalf of Students International Committee of Dental School, Tehran University of Medical Sciences, I should like to sincerely thank all our esteemed speakers for their valuable insights and contributions. Thank you so much.
Okay, thank you very much, Professor Thananphum, for sharing your time with us. And the next one, I must say, thank you, Professor Gorter. It's a great honor for us to host you again in this program.
Thank you. It's a pleasure.
And also Professor Muneer, it's a great pleasure for us to have you. I will be in touch with you for joint program. I was thinking about several joint programs and also research projects with you.
Sure.
Thank you for your time.
Thank you for having me, and it was pleasure. I learned a lot. Thank you so much.
Our pleasure. And Professor Mirzazadeh, it's a great honor for us to host you in this program.
Thank you so much.
Thank you very much for sharing your time. And I would like to thank you, the participant, for being with us. We will definitely share the link address of the recorded video with you all to follow this program. By the way, this is the last session that we have Amirhosein. He's definitely our talented students, and he will graduate in several months. And thank you, Amirhosein, for assist international office of the School of Dentistry during these years. Thank you. And
Thank you so much, Professor Shakib.
I'm sure you will have a great, bright future ahead, and wish you all the best.
Thank you so much. It's a
All the
pleasure.
best.
Thank you very much again, and have a
Bye.
great day. Bye-bye.
Thank you.
Thank you,
Bye-bye.
and thank
Bye.
you. Take care. Bye.
Nice
Bye.
day.